in for knee surgery and I come out in an hour and I have a tube because I was under general, but I wake right up, I'm not gonna have to be weaned. You wake me up, you just take the tube out, you know I'm gonna do fine. That's discontinuation, okay? All the people you see at the ICU, we have to wean them, right? And you've seen people now trying day by day by day where you wake them up. Do they behave? Do they act right? Then we can try to get them to breathe on their own. And most of the time, you wake them up, you put them back down. You wake them up, you put them back down because they just wake up like a monster, right? And then end of life care is a whole separate process, especially when there's organ donation involved. So we're going to try to talk about those and differentiate a little bit. And then when and why each of these situations applies, and do I have to have orders for all of these? That's a good question. Do I need an order to extubate?
Yes.
You do, right? Do I have to have a really good order to say I can take you off your vent to die? Please, because I don't want to be sued for murdering you. That would be terrible. And then we're going to look at the minimal acceptable values that would either say somebody could come off the vent or that they're sick and need to buy a vent. Okay, we're going to talk about that too. So disconnection is when we don't need ventilation anymore. Okay, and we just needed it for a short period. I like to think about, and the boards like to use this example of a drug overdose. So you had patient X who hit the ER, having had a whole bunch of pain meds outside on the street, or hopped up on meth or whatever. They overdosed on their narcotics that they like. They come into your ER, you give them a whole truckload of Narcan, but they were intubated in the field. Well, that might turn them around. You got to watch out for Narcan, though. What about Narcan? It has a really short half-life, right? So it may work for a minute, and then it's going to stop working, and the narcotics are going to pick back up. So we have to be very careful when we just go to extubate somebody who has a narcotic overdose, because odds are those narcotics are going to hit again, and they won't breathe. Okay. But if you fix them and they're good and they're awake and behaved, then you can just take the tube out. So you want to think about that. Sometimes little old folks who should have come out of anesthesia pretty well don't. Okay, and they just need a little longer and pack you with the tube down. But I don't have to go to the process of weaning you. I just need you to wake up and take the tube out. Okay. And of course, end of life care. Have any of you had an opportunity, besides Kira, because we did it last weekend, to take somebody off the vent to pass? You have? Yeah. Unfortunately, thanks to COVID, we've had a lot more of that than ever before. And so Kara was asking me, do we want the family in the room? And I personally don't. I don't want that to be the last memory, is them watching me pull an OG tube that's full of yellow crap this long out of the mouth, and then pulling an ET tube out with Vavas and God knows whatever else stuck to that. I don't want them to see all of that. So I personally ask them to step out. And a lot of times the families are like, I'm just stepping out. They don't want to watch it. You get those rare circumstances where somebody wants to be there for it and you just kind of have to do it. But I don't want them to see all the stuff that comes up, how you have to suction. I don't want that to be that family member's last memory. They're going to walk in, and like what Kara and I did, we just took the tube out, and then we, the tape was off, and she looked all peaceful, and we left. And we sneak out, and the family comes in and we grieve. And that's how you avoid that whole getting sucked into the crying situation that's going to happen too. You're done, you leave, they come in, and they do what they got to do. Okay, so if you have issues with family like that, I get the nurse to back me up, and I just say, hey, let's go ask them to step out real quick, because it only takes a couple seconds to extubate somebody, especially when you're doing it to terminally wean them. Okay, so end of life care. Remember, we should have the option to decide when we want to die. We're humans, we do it for pets. Why on God's earth do we not have that opportunity for ourselves? You should be able to say you don't want care anymore. And ideally it should be your choice. But sometimes it's someone else's choice because you can't speak for yourself. So who is the person making decisions for you? As you sit here in this room, do you have somebody who'd be willing to make decisions for you? Have you discussed what your wishes are with family? A lot of people don't, especially when you're young. You're not thinking, hey, I could have a catastrophic car accident tomorrow and wind up on a ventilator. Would your family know what you would want? Most people would say no. So who's making those decisions for you? The goal of end-of-life care is to allow the patients to die with dignity and respect, with the ability to control how and when it happens. Okay. We can do that a lot of different ways. There's something called advanced directives. Do you know what those are? Okay. So that just means I go to the hospital, I say, I want this, don't do this, don't do this. Whatever it is I want. Okay. And that can also be done as a durable power of attorney. So for my mom, for example, I am her financial and her medical power of attorney. They are separate entities, for those of you who don't know. Okay. So I can make medical decisions for her, but as next of kin, I would make them anyway. Okay. As your wife, next of kin, she can make them for you. You're making them for your grandpa. So as next of kin, you can do that. But having legal documents always help with that. Diego and I were talking about this with your family that's from the other state who want a say, right? You and your aunt know what's to happen, but you guys already know what you're doing. They could come in and say, hey, this is what you should do. Not good. There's also a healthcare proxy, so you can have somebody act on your behalf who's not related to you. Maybe it's a best friend, maybe it's a child, and the state has had to get involved. Okay. DNR? DNR does not mean do not treat. Write that down in big fat letters. DNR does not mean do not treat. I get really irritated when I hear nurses say, but they're DNR. And I'm like, but they're suffering. And they can fix that. Okay, so the patient should be allowed to die with dignity and be as pain-free as possible. And I hear people say, well, they're DNR. Well, who cares? Kiara, do you remember that lady that we had in room 3 who hacked up a lung the whole day and she was miserable? Who even went in there except when she tried to fall out of bed?
I was a bit confused about that. She looked very upset and I didn't see anyone go in her room.
End-stage COPD, she wasn't even on any kind of lung meds. They weren't giving her any morphine to help with her work of breathing. She was very uncomfortable. She kept slopping forward, slumping sideways. She tried to fall out of bed one time, totally miserable, begging for help. Nobody went in there. I asked that nurse down about it, and she said to me, well, she's DNR. I'm like, so? So, what does that mean? That doesn't mean you don't treat. Makes me crazy. But DNR and do not do stuff to me are different things. So you can say, I don't want a blood transfusion. You can say, I don't want to be intubated. You can say, I don't want you to do CPR. You can say, I don't want drugs in a code. But you have to line out specifically what it is that you want. My personal opinion, if you're going to do the full-on code, do it all. Do drugs, compressions, airway, all of it. You'll have people, and you've probably seen charts now that said, this person's a DNI, but go ahead and do compressions. Ugh, what for? Or give drugs, but don't do compressions. Well, then the drugs are sitting in the IV. What's the point of that? You might as well wash their hair with it. It's not going to do anything. But doctors are not really good at explaining to families what that actually means. They're also not good about explaining what happens in an actual code situation and how CPR is done and the process of breaking ribs and things like that. So I've actually had providers that I work with, nobody wanted to code the little grandma because they knew first pump, every rib of hers is going to pop. And this family was insistent. So the doctors made the family stand there and watch it. Like, well, that's not cool either, because now that's their last memory. But they don't understand. They think you just magically bring somebody back, and we do bring people back. But to what end? You can also say if you want to be defibrillated or not. Okay, so again, my personal opinion, if you're gonna do it, do it. If not, give me a bunch of morphine, send me on my way, or just walk out of the room. I'm halfway to heaven anyway, leave me alone, right? Okay, so palliative care and hospice. You need to know these two definitions for the board exam. This is a new thing that's popped up on the board. Palliative care is controlling pain and other symptoms of a terminal illness. It's different from hospice in the fact that this can go on forever. People have had think about Lou Gehrig's disease, ALS. Those people can suffer for 5 years. Okay, they need to be on palliative care to try to make that more comfortable. Okay, it maximizes psychological, social, and spiritual well-being of the patients nearing end of life. That is a World Health Organization definition. That's what you see on the board. That's also on your quiz. Okay. Whereas hospice care, and I didn't understand this until I actually had to interact with hospice when Grandma Sanchez was dying. I didn't know this. I didn't realize how it worked. I'd seen it a lot in hospitals, but I always thought when the patient was 2 days from death, that's when hospice got involved. Hospice can be a part of your life for several years if that's how it goes. The great thing about hospice, which I found out, is they actually come in and take over the care of the patient, which means for Grandma, they ordered labs for her. They had medications changed for her. They got her more pain meds when she needed it. They upped her nutrition when she needed it. They handled all of that in her care center that she was in. The physicians for the facility didn't do anything. Hospice did it. They would call hospice and say, this is what's going on, and they were like, okay, do this, do this, do this, do this. And her transition out of here was very smooth and comfortable for her because of that. That's what hospice does. So it's it's care which helps support efforts in terminally ill patients by providing a clinician to cover and equipment at home, and also to be there for the family. And that's something else a lot of people don't realize. Hospice is there for the survivors. They often will call after the person has died and check in with you. I still get calls to this day for the people who handled my dad in April. They still call. They offer counseling. They just want to make sure you're okay. You're getting stuff from them in the mail, how you doing, they stay with you, which is really kind of a cool thing. And like I said, the whole goal is to make your person transition without having to suffer. And I told them when they took my dad to hospice, I said, you give him as much morphine as you can without being arrested. And she's like, yes, ma'am. And I'm like, absolutely. I said, just as long as you won't get charged with anything, I'm not going to say a word. I don't want him to know anything. And he was gone that night. And that's exactly how it should have been. No suffering, none of that. Just go, be gone. Be gone with you and go to heaven. So know those two definitions, okay? Palliative care versus hospice, they are similar, but they're not the same. Now, another piece of this has to do when you're trying to rule out if somebody is brain dead, okay? You have somebody who, this actually happened in the hospital. Did you go over there and see that brain dead person? Mm-hmm. So what was the deal? I didn't catch the whole story. So I guess Sunday they had somebody come in through the ER that had what was his issue? Did they tell you?
I don't remember. It was just some kind of.
Did he have like a hemorrhage
I don't think it was. Yeah, I don't think it was a TBI. I think it was like an anoxic brain injury or something
anyway,
like
so
that.
The patient came in through the ER, had to get intubated, was breathing all kinds of crazy. Then they decided that he was brain dead. So they were going to take him to the ICU and make him an organ donor. Well, guess what? His brain wasn't done. So he was like, I'm still in here. And then it kind of shifted everything around. So when you're trying to determine brain death, there's lots of things that we do, okay? So one of which is actually a physical maneuver that we do with the ventilator where we take them off the vent. And before we do this, though, write this down, their vital signs have to be stable and their blood gases have to be normalized. So when you're doing an apnea test for brain death, they have to have normal vital signs and their blood gases have to be stable. So a lot of times somebody will say a patient is brain dead because they're not trying to overbreathe on the vent, or they're not responsive to the person in the room. Maybe they don't respond to pain, okay? So in that instance, what we do is we actually take them off the ventilator. We put a catheter down in the endotracheal tube with oxygen blowing 100% at the crina. Just putting oxygen in there, okay? Now, in theory, as you guys already know, if your CO2 builds up, what happens to your respiratory rate?
Okay.
No, if you got CO2,
Increase.
right, because your body's like, oh, I don't like this, I'm gonna blow up my own CO2. Here's the same theory. So if you're giving them 100% oxygen and they don't breathe, well, their CO2 is gonna climb, okay? So we do a serial run of blood gases, and Lovelace's procedure, I believe, is every 3 minutes or something. So you're poking them for blood gas every 3 minutes, and then you're running the blood gas, and then you're coming back and poking them, and you're running blood gas. And what we're looking for is an increase in CO2 and a drop in pH without them trying to breathe at all. Because if their brain stem is intact and the respiratory center works, the brain is going to say, hey, you should breathe. I need you to pick this up. You're dropping the ball. Breathe. And they should breathe if they are able to. Okay? So we disconnect the patient from the ventilator and give 100% FiO2. We monitor the vital signs still. We observe the patient for any chest or abdominal movement. That should be an OR, not an O. And we look to see if they try to breathe. Absence of respiratory movement indicates a positive test, which means the patient is brain dead. Diagnosis is further confirmed by a cerebral perfusion scan. They call that a cerebral angiogram. They used to do awful stuff like putting ice water in patients' ears to see if they would move. Would that make you jump if you could? Or they used to do stuff like poking people with needles in their toes. Because again, if you could get away from that, you would. So they used to do a lot of awful stuff. So once they've proven that somebody's brain dead, well, then they can think about withdrawing life support. Again, we have to have family and friend buy-in, right, if that's who's at the bedside, or an order for it. Or there's also ethic committees at the hospital where if you have a patient who is not able to speak for themselves and there's nobody to speak for them, well, then they can go to ethics committee and have to be decided like that. So when you're withdrawing life support, we're taking life support and any other unwanted medical interventions when our therapy has not worked and the patient's not going to survive, okay? And have you guys seen anybody go from full support to be a DNR or to have the tubes pulled and they just stop everything? So like our lady that day, and I think Diego, we had a patient like this too. They just stopped all the pressor meds because they don't want to keep that going. Turned up all the pain meds, all the morphine, all the sedation, those are cranked high. We took off all the IV fluids, we stopped all the nebs, we stopped everything, and then we just took the tube out. And it's usually a matter of minutes, depending on how strong the heart is. before they pass. A DNR has to be in place, and then there has to be document signage saying that it's okay to do what we're about to do. Which I said, they keep talking about euthanasia and how we don't do it. Yes, we do. We just don't call it that. Exactly what I'm describing to you is what you do for a pet that you're wanting to put out of its misery. We're doing the same thing for a person. It's just not called that. And they don't allow you as a patient to make that decision for yourself, and that's not right. That was the whole Jack Kevorkian thing, right? He was trying to say you should be able to die at home with a terminal illness on your own behest. You should be able to say, I'm done doing this. But then that leaves other ethical battles, and I don't know if you talked about this with Dr. K when you had your little portion of ethics class. When my friend Diane used to work here, that caused a huge debate. So I have ALS and I want to die and I'm going to take my little pill and go to sleep. Okay, but what if, no, I'm just super depressed and I think the universe is terrible and I want to take my little pill and go to sleep. So it gets into kind of an ugly gray area, and that was why they had a problem with Dr. Kevorkian. Okay, so comfort of the patient in this case is paramount. We have to keep them comfortable. And not only that, be respectful for the people in the room. You may not have seen a patient die yet, and they may not have had anybody die. This is the first time they're facing it. It's somebody that they dearly love. And subtle things like walking up and handing a box of tissues to somebody who's crying at the bedside makes all the difference in the universe at that moment. Okay? They might not remember you, but later they're going to be like, oh, that was really nice of that lady who I didn't know, didn't ask for, just kind of slid in and did something unsolicited. People also get very dramatic sometimes, and there's lots of, they fall all over the bed and they're crying, and you see that on TV a lot, but it does happen. Kids, I don't like watching kids when the parents have to go. We took a lady off about a month ago. She had COVID. She was 43, I think, had 4 teenagers. They were all in there wailing. I mean, absolutely wailing. It was horrifying to hear it. And, Dad was trying to keep it all together, and, they're taking Mom off the bed, and the kids are just laying all over her. It was so disgustingly sad. Oh, it just broke my heart. Mom, COVID, not vaccinated. I'm like, yes, I'm sure her kids are really mad now. So the process of terminally weaning is when we're discontinuing mechanical ventilation due to irreversible illness. So we don't wean, we're not doing anything, we're just turning it off. Okay. We try to treat the tachypnea and dyspnea with any drugs like benzodiazepines, barbiturates, pain meds, absolutely. And if you haven't seen it yet, you will. The nurses go in and they get very liberal morphine orders and fentanyl orders and whatever, just crank it up. Crank it up. Because you don't want the patient to be air hungry off the vent. Another thing you don't want the family to see. Again, you don't want that to be the last memory of your mom or your grandma or whatever is that person lying in bed like that. Okay? So questions about that? Okay? Well, now when organ donation gets involved, and again, there's a little something different about this. So once you've proven brain death and they're going to harvest the organs, the organ donation team comes in. And they usually run the care of the patient after that. They're the ones who write the orders for meds, they change things on you, ask you to do different stuff with the vent. They're the ones wanting serial blood gases, they're the ones doing it. Because what they want to do is maintain adequate oxygenation and ventilation to keep the tissues harvestable. So the heart has to work, hopefully the lungs are still working. Whatever they're trying to perfuse to use, like your kidneys, whatever they're taking, we need to make sure the person is going to have as good of an acid-base status as we can get it. So you want to just basically keep blood gases normalized. That's the way to think about it. And we also have to maintain circulation and perfusion. So blood pressure has to be good, okay? MAP needs to be about 60 to 65. Where's that 60 number coming from? What did I say about 60? Do you remember what happens to your kidneys?
No, you need that to be able to perfuse the body.
Absolutely. So I have to have a MAP of at least 60 to perfuse anything, so especially my kidneys, okay? I want to keep my cardiac output normalized, cardiac index normalized, CVP somewhere in a reasonable range, and I want to keep the kidneys working, so I need to make sure I still have urine output. Okay? Keep hemoglobin stabilized and hematocrit of at least 30%. That's not normal, right? What's normal hematocrit?
45.
Right. So it's not quite as high as normal, but it's pretty decent. Maintain temperature. We got to keep them warm enough. Maintain normal electrolytes, normal glucose, or it's a little elevated glucose they tolerate. And then because the person's brain dead, you want to tape their eyes shut because a lot of times they're going to use the corneas or some part of the eye for transplant. So we don't want them to open up just to atmosphere. And unfortunately, when you're brain dead, you can't shut your eyes. Okay. Okay, so that's discontinuation and organ donation. Any questions? Okay. So weaning is what we do mostly, and this is what we do all the time. Weaning is how we're gradually withdrawing support from the patient, from the ventilator, and hopefully they jump in and pick up the slack. And I get asked this question all the time from families. They're like, well, how do you know when the tube's gonna come out? And I'm like, I don't. I wish I had a crystal ball that said by Tuesday at 4 in the afternoon, Mr. X is gonna be off of N. I wish. We just don't have that kind of capability. Sometimes they come right off and do great. Sometimes they look like they're gonna do great. Kira, that man that we weaned, thought he was looking fantastic, and he lost his damn mind on the ventilator. Like, he went absolutely panic attack mode. And before we flipped him over to spontaneous, he was calm, he was watching TV, he was like, yes and no answers, so good. We're like, you're gonna do great, and he flipped the hell out. We had to hit him with a truck to knock him back down. Like, she drugged the crap out of him to calm him down. He really lost it, he flipped out bad. And I didn't expect that at all. I thought he was gonna do great. So, I was like, oh shoot. And then some you wean and you're like, oh, I'm gonna flip him to spontaneous and he's gonna do horribly. And they do great, you just never know. There's so many things that are a factor here. So, weaning is a very lengthy process in comparison to just discontinuation, okay? And patient usually has some sort of a lung problem happening concurrently, or they have heart disease that's going along with our weaning challenges. So again, as you know, a lot of our patients who have to wean have been vented a long time. They probably also have comorbidities we have to address. Okay, so when we're gonna wean, and we discussed all of this in 210, so if you don't remember, you might wanna pull out your old notes from your airway class, okay? When we're gonna wean somebody to extubate, I have to make sure that whatever they got intubated for is resolved or is resolving. Okay, did I make it better? When I go to extubate, I need to make sure, and I'm gonna wean, I have to make sure that the nurse has turned off most of the sedation, right? Certainly the paralytics have to be turned off. I can't wean you if you're still paralyzed. I want to make sure that the tube feeds are off, right? Because if I'm going to extubate you, I don't want you to throw up something. Sorry about my phone. One of my husband's aunts died and they're in a big group chat. Quiet. Aunt or a cousin. I'm not sure. I didn't know this lady. I don't know who she was. Be quiet. Okay. So I need to make sure that the patient is sort of alert and aware and hopefully cooperative. It's not to say, when you guys come out of the OR and you've had surgery, you're still asleep, they take your tube out before you come out into the PACU if possible, because you don't want to wake up with that thing. So you're often extubated during surgery before you can get out into the PACU. But a lot of our patients are already in the ICU, have been there for a while. We want them to be awakened, can help us a little bit. I certainly want to know that they can follow directions. I want to know that they have a decent cough when I section. I need to consider the pulmonary status as a whole, because if they're drowning in mucus, I need to be careful before I extubate you. If you can't cough that stuff up once I take the tube out, we're going to have trouble, right? And coughing through a tube is terrible, right? It's very hard to do. It's not something easy, but if you take the tube out, they might do better. Hemodynamically stable without shock. Do I have an order, and is the tube feed off? Now, I have to be on the same plane as the nurse with this, right? We both have to want to do it. We both have to be ready to do it. When I go to wean somebody and I take them from a mandatory to a spontaneous mode, I'm not going to be the one to stand there for the next 30 minutes. But the nurse has only got 2 patients, so she's going to be the one to check on the patient a lot. So make sure you're communicating with them, this is what you've done. Now, can they breathe on their own? I don't know. Let's flip them over and see. I'm going to take you out of full support, or even SIMV where we're sharing the work. I'm going to put you in a spontaneous trial, and I just see what you do. Will you remember to breathe? Do you have an adequate respiratory rate, but also is the tidal volume adequate? When you put somebody in a spontaneous breathing trial, we use pressure support ventilation. Okay, no rate, but we're adding pressure. The pressure is to get past all of the dead space. Okay, you want to give a little pressure so the patient doesn't have to suck wind through 8 feet of tubing. Okay, that's what pressure support is. So remember, on the 980 and the other pyramid at 840, when you put them in a spontaneous trial with pressure support, it defaults to 0, which is stupid. So you gotta set it. Otherwise, you're turning it on, they have no help to get past all that tubing. Okay. So I want to make sure the person can breathe, they want to cooperate, they have adequate pain control, right? Because if you've got that lady we had, she had a hot gallbladder, her stomach erupted basically. She wound up with compartment syndrome. So they opened up her belly and filleted her and put a wound back in there. And she was breathing like a monster. And I told the nurse, I said, she's got to be in pain. Well, she's not awake. Doesn't mean she has to open her eyes to be suffering. I'm like, I should know I should know more than you. And they gave her a little bit of morphine. She chilled right out. I'm like, she has an open abdomen, people. I can't feel good. Okay, so pain control. Are my vital signs stable, or at least baseline to where they were before this whole mess started? Because remember, our COPD patients have funky blood gases. I may not correct that 100% because their bicarb's always going to be elevated. Their CO2 is always going to be elevated, but is my pH normalized? That's the important part, okay? Do they have any heart issues I need to deal with, or arrhythmias? And do they have protective reflexes? You might not know until you go to suction. Maybe they're not coughing. Is everything else normalized? Okay, so I make sure they don't have a fever. If they have a chest tube, I want to make sure they're not profusely draining from that chest tube, because that's also a real bad sign. And then if they don't have anemia, because remember, you can't carry oxygen without hemoglobin, right? So if I don't have enough of that, probably need to reconsider my extubation process. So how did we get there? Well, honestly, at ICU at Loveless, I put you on full support. I wake your butt up. I flip you over to a spontaneous trial. Who's seen that? All right? Everybody's seen that. The boards will let you take as many short little stupid steps as you like. Okay? So I can go from full support, which would be volume control, volume with pressure support, PRVC, whatever, something where you're mandatory giving everything. And then you can go to SIMV and switch the patient to where they're sharing the work with you. The boards find that perfectly acceptable. Okay? On a real person, you may not be putting people in SIMV. Most patients hate it because it's going from tons of help, no help, tons of help, little help, tons of help, no help, and they can't keep up. It becomes very asynchronous instead of being nicer for them. So when you get to clinicals, you may not see a lot of people in SIMV, but you can totally use it for the boards. They will let you wean with SIMV, and they'll even let you turn the set rate all the way down to 8 in SIMV. They may even let you extubate from an SIMV rate of 4 and say that that's okay. Okay? But in my mind, I'm going to go straight to pressure support, and I can do that with or without CPAP. So there is a mode on the ventilator called CPAP. You can do that. Or you can do pressure support with a PEEP. The point of weaning is that I don't have a set rate going on. Okay? Now below that, there's something called closed loop mode, where some of the ventilators have special software built in to better sync with the patient and help support them through their weaning process. Old school, had my friend Bob over here intubated. I wanted to wean him. I took him off the vent. I put him on a TP, so the Briggs adapter, and a heated aerosol, and that was it. He was on a monitor. He got to breathe through 8 feet of tubing, and I just watched him until he crashed. Right? Or gave him long enough and he held on and I pulled the tube. We weaned everybody in post-anesthesia care unit PACU like that. Everybody went, got an aerosol set up, that's how they weaned, and then they were extubatable. Okay? The boards will still let you do that. You can put them on a T-piece if you choose to. I'm not doing that to a real human because guess what? On a ventilator, I have apnea parameters. And I can back them up. If they stop breathing, the vent will pick it up, and then the vent's going to scream and say, hey, guess what? Get in here if you stop breathing. Okay, so we don't do that anymore to real people. But the boards, you absolutely have the opportunity to put them on a T-piece trial instead.
You can put a T-piece on a AT tube?
Yeah, it's with the Briggs adapter. It looks like the little neb tee that sticks to the AT tube. Yeah, you can. Now the other closed loop modes, auto mode, volume support, MVV, and adaptive support ventilation, these are all ways of guaranteeing some help, okay? So auto mode is on the servo, and what it does, and we're gonna play with this next week, auto mode basically just takes the rate away. So it doesn't matter if the rate is set at 10, if the patient starts to breathe, well then the vent does not deliver the 10 breaths that you've set anymore, it lets the patient breathe spontaneously, but at the tidal volume you picked, okay? Volume support is considered a weaning mode because we don't have a set rate either, but we're targeting a volume to set. So I'm gonna say I want Diego to have 400 mLs of volume. The vent is gonna give that. I'm just not gonna say how many times a minute. So to me, is that really weaning? I mean, if I'm guaranteeing your volume and I just wanted you to decide how often you're breathing, is that really weaning? I don't know. MVV stands for maximum ventilation, maximum minute ventilation, where you're telling the ventilator, I want Diego to have a minute volume of 6 liters a minute, and the vent will do whatever it has to do to make that happen. Adaptive support ventilation, ASV, is the same thing. That is on the Draegers. And what that does is it gives you pressure changes to augment volume. So you're targeting a volume again, and the ventilator is going to change the pressure support delivery in order to make those volumes happen. Okay? And then we have one called NAVA, N-A-V-A. I think that's coming up on a future slide. NAVA stands for neurally assisted ventilation. And that involves a catheter that goes inside the patient's stomach that hooks up to the servos, and it senses electrical impulses from the diaphragm. So it's actually picking up way before the person's trying to actually breathe where you can notice it. That is so sensitive, it's seeing the diaphragm just twitch, and it's like, oh, they want a breath. Problem. The nurse has to put that line in the patient's stomach. We don't. And they don't like it because you can't, it's not like suctionable through there, you can't infuse fluids through there, so it's not wonderful yet, but the technology is pretty nice and it's coming along. So as we're weaning from mode, and there is no black and white way of saying you are gonna every Tuesday do this, going from volume control to SIMV to pressure support ventilation to TPs, there's none of that. Okay, you're gonna see all kinds of iterations and variations of this process. The key is just, do I have enough backup help in case the patient gets in trouble? And I don't want to extubate anybody with really full settings. What I mean is I'm not going to extubate somebody from FiO2 100% and a PEEPA 10, right? Because they're too sick to come off the vent. But as you get closer to 40% and a PEEPA 5-ish, well, that's pretty safe. I know that you can handle that. Okay, so that's the last statement on here. PEEP has to be less than 10 because the board's considered 10 therapeutic PEEP. I like to have you more around 5 or 6 because I know that your alveoli are staying aerated and I don't have to worry so much. And sometimes people, we try to wean them, and we call them daily awakening trials. Have you seen these yet, where they turn off all the drugs and see people wake up and behave? And that's the trick usually, because they can't behave. But they get wild and crazy, they get knocked back down. Try again tomorrow. Tomorrow they wake you up. So think about this. Imagine, have you guys ever been in such a deep sleep that you were startled by a noise? And you just suddenly wake up all jolted and you've got that fight or flight thing happening and you don't know what's going on? Maybe like when the lightning is hit in the middle of the night, and it's just, I've had that happen where you're totally out, dead sleep, and all of a sudden, boom, and you're like, what the heck? That's what happens to these people. The drugs are on, you're dead sleep, things are good. All of a sudden, we turn off everything. Hi, it's daytime, wake up, Mr. Bondsmith, and then you wake up like, whoa, where am I at? Some people don't always play nicely. We want to hope that they will, though. And then the more longer they can stay awake and calm on the vent, then we know they're probably going to do okay integrated. Sometimes they're just maniacish, and we just turn everything off, let them go bananas, and we pull the tube and just pray. Because sometimes they don't tolerate the nice, calm weaning process. You just got to get the tube out because they're going to go insane if you don't. And you're going to see those people, believe me. Okay. So SIMV, the ventilator synchronizes with patient breathing effort unless they're breathing crazy, won't help. Patient can breathe spontaneously to exercise their respiratory muscles, and those spontaneous breaths are the pressure supported breaths. I've showed you guys this in the ventilator. Does that statement make sense to you? So in SIMV, they have their standard volume or pressure controlled breaths. The extra breaths, the spontaneous breaths, now become pressure supported breaths when you set pressure support. Does that make sense? And you see your C, and then you see your A, and then you see your S for spontaneous, right? Okay, if that doesn't make sense to you, remind me next week and I'll point it out again on the vent. We can turn down that SIMV rate for the boards. You can slowly wean it. Okay, it's going to torture you if I take you as a real patient and I take you from a rate of 16 to 14 to 12 to 10 to 8. No, I'm not doing that on a real human. But the boards will let you take that very slow road to China and wean slowly if you choose to. They may also flip it and say, hey, this person just came out of PACU and they're doing great and they're awake and they're aware and they're calm, and I could pull the tube. Okay, so you're going to get into this more when we do scenarios in Dr. O, but look at what's happening with the patient. That'll help you pick what you need to do. Okay. So SBTs are called spontaneous breathing trials. We put the patient on pressure support mode, and they control the respiratory rate, the size of their own breath because they're using pressure support. They also control their eye time and their flow. So they get to decide what they want it to be. The mode is patient triggered, pressure limited because you're setting pressure support, and it's a flow cycled mode. Pressure is constant because you're using pressure support, and so your volume can kind of be all over the place. And you're going to see some patients who actually have tremendously high tidal volumes on pressure support when you only have them set at a tidal volume of 400 on the vent. when you had them on a rate and everything. And then all of a sudden they get all this extra pressure, and like, wee, life is good, I can take these big, huge breaths. They might calm down. Because you think about, we do lower tidal volumes, you know, our 8 mLs per kilo to protect their lungs, right? They might actually want to breathe deeper than that. And so you give them some help. They take suddenly an 800 tidal volume, and they're like, this is fabulous. And they do it less often. So their rate might decrease. The tidal volume could go up if they look calm. Does that make sense? Okay, and sometimes you have to play with it. So guidelines, we want to set a level of pressure support to eliminate work of breathing. So like I said, for me, I typically start off at about 10 centimeters of water pressure. And then if you get really monster volumes, I'll back you off until I get to about 6 centimeters of water. And that's just to overcome all the dead space. We want to get rid of the mechanical dead space. We don't want the person struggling. We're trying to help them with their work of breathing. You can set CPAP as a mode, or you can set a PEEP. So typically, the new ventilators, you're going to hear somebody say, patient X is in a spontaneous breathing trial at 8/5. Write that down, 8/5. What they mean is the 8 is pressure support, and the 5 is PEEP. Which works very similarly to BiPAP, right? As you're breathing in, you've got that 8 centimeters of water to help you breathe in, and then you're exhaling to a PEEP of 5. Make sense?
Could you repeat that, please?
Yeah, so we know how in BiPAP you have 2 pressures. This is kind of similar, to where you're using 8/5, and the 8 centimeters is when you're breathing in, you have that help. And then that stops, and you exhale to 5 of PEEP. Okay? Most people, when they're awake and aware, like this better. And you'll see therapists who's got kind of a crazy wild patient who's not really necessarily interacting with you, but they clearly want to control their breathing. I'll flip them to a spontaneous trial and see if they like it better. Sometimes they do, sometimes they don't. Sometimes they get better, sometimes I'd love to get them drugged. Okay? So this is kind of the last step from a hospital standpoint before we pull that tube. Okay? But the boards would let you take them to a TP trial from here. Okay? So when I'm weaning somebody, there's a lot I have to monitor. So I need to make sure that their spontaneous rate and spontaneous tidal volume are good, that the vital signs are good. Now, you're going to see in the hospitals in Albuquerque, we put people on a spontaneous trial for hours, sometimes all day even. Sometimes for 24 hours, depending on how they do it. The boards are very specific. They want you to start at 30 minutes and go to 2 hours. That's the first trial. Watch for tolerance. If you pull out your pursing book on page 133, it tells you everything that's going to signify somebody who's not tolerating. And it should be common sense. Now, rate's really high, tachycardia, stuff like that. Okay?
So for the 30 minutes to 2 hours, are you saying like you start off with a 30-minute trial and then gradually increase it
Correct.
with every subsequent trial?
Correct. Now, what I've seen as a board question here is, you've had a patient who did a 2-hour trial 3 days ago. Yesterday was a 4-hour trial and everything looked good. Today was a 6-hour trial and things don't look good anymore. So what do you do tomorrow? And you're going to be thinking, we'll put it back on the vent. No, what they want you to do is go to the last trial time that they were good. So go back to 4 hours. You can't push it to 6. Does that make sense? That's a board question all day. I've seen it multiple times. Okay. Now, if you wanted to, you just use CPAP as a mode on a ventilator. And a lot of the new vents don't necessarily offer the CPAP just by itself because you have pressure support over PEEP, same thing. But CPAP old school was basically like using a T-piece but with a ventilator. So it had the safety features of the apnea alarms. And I want you to write down somewhere, make sure you're checking your apnea parameters. You're going to have a time interval for the apnea time. So for adults, it's 20 seconds. Pediatric patients, it's 15 seconds. Neonates is 10 seconds. So adults 20, kids 15, babies 10. The bigger the being, the longer you get to figure it out. Okay. So with apnea parameters, you have the option to set backup parameters. You can set the mode they're going to be in. You can set a tidal volume and a rate and an FiO2. So it's going to back up ventilate them with whatever you set.
Who did we put? We put someone on CPAP on Sunday, and I can't remember who it was.
It was 2. That guy that flipped out.
Yeah, okay. So I
Remember,
wasn't
we
sure
had
if
to
it was
check-
2 or 7, because we put 7 on a spontaneous trial for a bit too.
I didn't leave him though, because after 2 and bananas, I was not gonna push my luck with 7, because I wasn't feeling as good about 7 as I was about 2, and he's horrible. Now, so remember to check your apnea parameters. So when you guys are out there at clinicals, check your vent settings, check your apnea parameters. So if you see my little cheat sheet that I made you, it does not have a slot for that. Okay, so make sure you get that down, because here's why. So if you're mandatory ventilation, you should never be apneic, right? If you're mandatory ventilated, you should never be apneic. But if I come along and I wanna wean you, and I flip you the spontaneous trial, excuse me, and I don't check it, I can hurt you. I can hurt you. If I don't make sure that you have adequate ventilation set up as a backup, and I walk away from you, you could not breathe, and then we're gonna be in trouble. So always get in the habit of checking that. You're gonna find a lot of therapists don't, because they're like, well, they're mandatory ventilation. And yes, they are, but I may change them at some point, so I need to double check, okay? So CPAP by itself, so like a CPAP of 5 as a weaning modality is not gonna be used on real people. Okay. Any questions so far? Okay. So we have our weaning parameters that we need to do. So ideally, we have made sure that the problem was reversed, patients are better, they're hemodynamically stable, all the meds that are gonna jack with my breathing abilities are off, tube feeds held are off. If they were getting, I have an order and the nurse and I are on board to try to wean and extubate, okay? I need to get something called weaning parameters. So that's gonna be things like your NIF, which is negative inspiratory force, or it's also called an MIP, which stands for maximum inspiratory pressure. MEP, and this is actually on your lab, okay, MEP.
Do they have the same values?
They do. So, NIF and MIP, the minimal acceptable is negative 20, and this is actually on your lab, the top sheet, they're all typed out there for you. Okay, the lab I gave you.
What did you say it stands for?
Negative 20 for MIP and
Negative
NIF.
inspiratory force?
Negative inspiratory force or maximum inspiratory pressure. Old farts like me call it a NIF, you guys are gonna call it an MIP. Okay. So other things we're gonna look at to make sure that we have, so we talked about our MIP, and then there's an MEP, which is maximum expiratory pressure. That needs to be at least 40 centimeters of water. I need to have, remember my rapid shallow breathing index we talked about before, your RSBI? That needs to be somewhere less than 100. One book says 105, who cares? Somewhere around there. The lower, the better.
Could the RSBI ever be too low? Okay.
It's gonna be too high. So, and remember, that's just respiratory rate divided by tidal volume in liters, okay? Respiratory rate needs to be somewhere less than 20. You don't want people off to Kipnick. Now, do we extubate people all day long in Albuquerque at a rate higher than 20 if they're breathing spontaneously? Oh, heck yeah. If we waited for them to all chill out and be calm and magical, we'd never get the too bad to anybody. Because sometimes they're panicking because they're breathing through a straw. You woke them up, you took all their pain meds away, now you're telling them to pant through a straw and breathe through 8 feet of crap. They're not gonna be nice about it, right? But at the NBRC hospital, where your patients are always well behaved, they'll breathe nice and calm when you go to extubate them. Vital capacity needs to be greater or equal to 10 mLs per kilo ideal body weight. Greater than or equal to 10 mLs per kilo ideal body weight. Or you can make your life nicer and just say 2 times their tidal volume. That's a minimum. And a spontaneous tidal volume should be greater than or equal to 5 mLs per kilo. All that's coming up here too. You guys are worried about scribbling, it's all coming up on a slide. So when we're trying to get, here's some other things too. Well, I'll get to it. It's like A gradient should be a certain value. Dead space should be a certain value. Blood pressure and pulse are supposed to be, we're going to cover that in a couple of slides. Okay. So I can get these maneuvers through the ventilator themselves, which I'm not going to bother explaining to you now. I'm going to show you on Tuesday. It's easier just to show you. And it requires, sometimes they have software built into it, so you just have to tell the machine to do the maneuver. Has anybody had the opportunity to do a NIF or vital capacity on a ventilator patient who's really on a vent? Yeah. It's really hard to simulate in here, but I'll show you what we're doing, okay? Open loop ventilator maneuvers are your NIF and vital capacity that you're gonna do on yourself next week, okay? So it just means, am I on the vent or off? Again, we talked about some of the other specialty modes for weaning. Mandatory minute ventilation, which is on the bear. Volume support, which is on the servo. Adaptive support ventilation, ASV, which is on the Hamilton Galileo, or a ventilator called the G5. And then we have auto mode on servo. You don't care. You're not going to be playing with all these vents. It's just they are coming out with modes now that are specially related to weaning in particular. Okay. So mandatory minute ventilation, you can set it with anything, but what you're going to do is you're looking for that target minute volume. I just said all this a moment ago, so you don't have to like write it all down again. We just talked about this. But we're setting a target minute volume, and so whatever the patient is not reaching, say I wanted the minute volume to be 6 liters a minute. If the patient's only doing 4, it will augment the tidal volume in order to get to 6 liters a minute ventilation. Does that make sense? It will turn something up in order to meet the difference. Okay. Whereas volume support, we set a targeted tidal volume, and the ventilator adjusts the level of pressure support based on a compliance and resistance calculation to get a better volume. Okay. Adaptive support ventilation kind of works the same way. And then an auto mode is the one where it actually takes the rate out of it. So I can set a rate of 15 on a patient. Who cares? The patient can start to breathe on their own. The ventilator will not deliver those 15 set breaths anymore. It's going to let you breathe how you want to breathe. But you still get this tidal volume or the pressure control that you had originally set. Does that make sense? So just take the rate out of it. Now, the nice thing about auto mode is if they can trigger 2 breaths in a row that are spontaneous, it'll flip them to auto mode if you have it on. And if they stop, say they go back to sleep, it will go back to the rate that you set, which is kind of cool. Auto mode is underutilized in my opinion. Now, like I said, you can go clear down to a TP trial for the board exam. I don't recommend it for people anymore because it's just not safe. But I will tell you also on the upside of having somebody intubated, I just tubed you. If all I had to do was control your airway for the board exam, that does not mean necessarily that I've had to put you on a ventilator. Perhaps oxygen and heat is enough, all right? If you're not having ventilatory problems, I don't need all of that, even though every person you tube gets one of these, right? They get a vent. Okay, so this is one of those things too where you have to separate what you're seeing at clinicals or if you're working, what you're seeing at work, for the fact that if I just had to protect your airway because you had a little bit of upper airway stridor, but you're breathing fine and your ventilation is fine and you're lucid and everything's great, I don't need to put you on a vent. I need to put you on a TP with some aerosol. Okay? We're going to practice some questions like that. So a TP trial, the patient is going to breathe spontaneously on a Briggs adapter, which is that little thing that looks like an FT, hooked up to the ET tube. Okay? Aerosol tubing over here, piece of small tubing here as a reservoir. No safety features, right? Back in the day, the only way we knew that somebody was not tolerating their TP trial was because their saturation would drop or would become tachycardic or hypertensive or something weird because it would desat. That's the only time we knew something was bad. So this is no safety features and it's very old school, okay? But the board talk about it. Any questions so far? So we touched on a lot of this back in 210 when we were talking about extubations. Any of it coming back? A little bit. Okay, so some stuff I need to measure when I'm trying to wean a patient, okay? Everything on the screen is important for us to look at, all right? Vital signs, how are they? Is the patient looking agitated and super restless? Because a lot of them do. Are they pooping out? And you're gonna hear that phrase a lot, pooping out. Well, what the heck does that mean, Miss Kathy? Well, you will know it when you see it, okay? Somebody could be great, all of a sudden their tidal volumes that were 800 or 600 or 500 now are 2. Or they're 300, and their rate that was 20 is now 40. They are giving up. It's too hard, okay? Don't push them anymore. It's okay to rest them back on the vent. And when they've been intubated a long time, we will often wean them during the day and then even rest them at night. Have you guys seen that at AMG or Kindred where you were doing that? We have somebody on spontaneous trial during the day, or even a T-piece, right? A heated trach collar, and then they rest at night on the vent.
This lady just did that. It was weird. She'd been doing so good, and then all of a sudden, her end tidal just like went through the roof, like into the 90s.
So they had to put her back on the vent at night?
Mm-hmm.
Yeah, it happens all the time. People just poop out, and this is what I'm talking about. So fatigue. The other thing too is sensorium. Are they acting crazy all of a sudden? Like, were they perfectly calm and now they're going bananas like that guy? Because that tidal wasn't a problem. He just had a panic attack. But he might act crazy if his end tidal was really high. Okay? Or he was starting to desaturate too. ABGs, are they looking bad? Okay, do I have shifts in my end tidal or my saturation on the monitor? Do I have tachycardia issues? Do I have new hypertensive issues? Because sometimes if the patients are looking really sleepy, that's when we're going to know they're not digging it. Right? They're now tachy, they're now hypertensive, their SpO2 is now a problem, and their blood pressure is sky high. They look like they're asleep, which is I couldn't get through that lady with the belly opening. The nurse is like, she's fine. I'm like, she's not fine, look at the monitor. Yeah, so she looks like she's having a nap. Inside she was being terrorized. And when you went around to her face, I don't know if you saw, she had tears coming out of her eye.
I saw that, yeah.
She couldn't open her eyes and tell anybody about it, but she was absolutely horribly trapped in that hell. And she finally gave her some drugs. Yeah, that little nurse is like a little bumblebee. She just goes over all the time. She gets it, but she was just busy. And then also urine output. So if you're starting to have blood pressure issues, the patient's not tolerating their weaning, you're going to see it manifest as a low urine output, believe it or not. Okay? I always get that question, well, why do you care about urine? I don't care about urine. Yes, you do. Because if your patient is not making any, you're going to have all kinds of problems with your weaning. The other thing to think about too with weaning, and I don't know if you guys remember this from your other class, but if somebody doesn't have any nutrition on board, are they going to be able to wean? If they haven't eaten for 5 years, are they going to be able to wean, right? I mean, if we can't feed them or we're only giving them elemental nutrition, are they going to be strong enough to wean? Right. Which is why we're trying to get people off the vent as soon as possible. You go on, you get better, you come off. Our COVID folks that have been down for a month and have been intubated a month, yeah, it's not a good situation. And, I have people asking me, in fact, Kiara asked me Sunday, why don't we trach this person? Well, because they're too sick. I can't trach them, even though you desperately need to, because that lady had an airway for a month already. And every time she moved, she had a leak. And all I could see in my mind was her trachea doing this. And every time she wiggled, that cuff got out of place, and I was just like, ugh. They changed the circuit on her vent and stuff finally, but her tube, they didn't change her tube. That has not been addressed at levels at all. I don't know if you guys are seeing that anywhere with people who have been intubated forever. Are they even trying to switch out these tubes? Because they can't be trached. It's probably not any safer to change out their tube, but wouldn't it be safer to drop a tube changer, switch out the ET tube? Can't do a trach. I don't know, it's not being adjusted. It's not being addressed. So what's going to tell me my patient is not tolerating it? All of that. So, are they now short of breath? Do they have crappy tidal volumes? Remember, most anatomical dead space for an adult human is about 150 ml. If you're ventilating somewhere just barely over that, you're not ventilating enough. Heart rate increases of 20% or over 140, according to the boards, is a sign they're not tolerating it. If they have shifts in blood pressure, either hyper or hypotensive. If they become sweaty and diaphoretic, they're not digging it either. If they have new onsets of any kind of arrhythmias, especially PVCs, that's another board favorite. They'll say, you're weaning a patient. In fact, this is the question on your final. You will see a patient, you're weaning them, all of a sudden you see multifocal PVCs. What do? Put them back on a rate. They're not digging it. Okay? Decreasing saturation and or deterioration of ABGs or increase in end tidal. Remember, we have all our people hooked up to end tidal capnography. If that's starting to go up, you're not having a good time. Okay? And also signs of increased anxiety, which could just be they're more squiggly in the bed, they just look uncomfortable, they're trying to kick, they're trying to get away from you, they're not tolerating it. You need to memorize these. Okay. Memorize. So when we actually figure out weaning parameters and we physically measure them, and again, I'm going to tell you guys, as a practicing therapist in this city, you're probably not going to be running around doing weaning parameters on everybody. In fact, I hate to say it, but most of the time the staff therapists don't even know where their right spirometer and the manometer live. What they do is they just flip them over, put them on a spontaneous trial. If everybody looks good, they extubate. Okay, but from a board perspective, all of these people that you extubate get weaning parameters. Okay, and you need to know how to do it both closed loop and open loop situations. We're going to talk about that now. Closed loop, the benefit is I don't have to break the circuit. I do not de-recruit alveoli. I don't lose PEEP because they're still on the vent. Okay. Test is performed while the patient is still attached to the ventilator on a spontaneous mode of ventilation. And I may need to think about lowering the PEEP. So the PEEP is pretty high. I don't want to do it with this because it's going to change my values. Okay. And what I do is I put the adapter between the patient's ET tube and the circuit, and I just have them do it through the circuit. Or if they have a ventilator that's fancy, I just tell the vent to do the maneuver and I coach the patient. And again, we're going to do this Tuesday. Okay, I'm going to actually show you how, and you'll do it on the ventilator. If I have anybody brave enough, I'll throw a clean circuit on and you can get a mouthpiece on there and coach each other. Just do the maneuvers, see if you can do it. So it's just a better way to get a feel for how to do it. So it's closed circuit, usually through the ventilator. There's software that'll usually let you do it, or you can actually put the rights in line, or you can put the manometer in line if you have to. Okay. Open circuit is I take the vent away and I just attach something to the ET tube itself. Okay, so I attach my rights, I attach my manometer just directly to the ET tube, and then I coach the patient. And you just saw the video about what would happen. You'll also practice that Tuesday. Okay. Okay, so our right spirometer, we do an SVC for vital capacity, not a forced. So you can figure out what your mLs per kilo are to see if they're safe. If you take the volume that they did for you and divide it by the ideal body weight, then you get mLs per kilo. That's that third statement down there. And if you don't remember how to coach each other, I recommend going to watch that video again. There's also a couple other videos on YouTube that are really helpful, just telling you how to do the vital capacity and the minute volume, the tidal volume on the right. Yeah. Closed circuit, we hit a button, we coach the patient what to do. Okay, so these next two slides are also very important. You need to memorize all these values sometime before you get out of the program. Okay, they're very important. This is stuff that the board is going to throw at you to see if you can identify if somebody's ready to wean or not, or to be extubated. So assessment for weaning, ABG should have corrected whatever they were and show adequacy of ventilation and oxygenation. Now remember, our COPD friends could have funky CO2, have a lower PO2, and a high bicarb, but a normal pH. That's normal for them. I'm not going to overcorrect that. Doing my bedside mechanics, I can get my rapid breathing index. We talked about that. Rate should be between 8 and 20. Vital capacity should be at least 10 mLs per kilo or 2 times ideal body weight. And just for your benefit, normal is about 75 mLs per kilo of total body weight. If you're going to do, like, if you could do a really nice vital capacity, that's what you could do. The minimal that's acceptable for me to extubate you is 10. Now, I can reverse engineer this. If I have somebody who has a neuromuscular disorder and they're getting sicker, and I come and do bedside mechanics on them, so let's say they started off at 65 mLs per kilo, they looked excellent. Remember, normal vital capacity is about 4.5 liters, okay? If yesterday they could do it at 3 liters, and today it's 2, and tomorrow it's 1, well, that's a huge sign to me they're in trouble. And now I can't trust that they're gonna breathe on their own. I have to think about intervening in some way with either non-invasive or possible intubation. So same thing with the MIP. Let's say yesterday they were negative 100, which is pretty normal. And today they're negative 15. That shows me they're not doing well. They don't have the strength to even take a breath to cough. Okay. MEP, normal is about 160. If I have the patient do it and I'm getting 80 one day and then 40 the next and then 35, well, I'm in trouble. Again, the patient's not strong enough to generate a cough. So you can use these meeting parameters as when to take somebody off of them, but also when to put them on a vent. Okay, if they're getting sicker, or to give them some other non-invasive positive pressure help. Does that make sense, guys? Okay. And the rest of them are there, we just talked about all those. Memorize these. If you're a flashcard maker or a Kahoot maker to study, this is great stuff to go on there. Do you guys make Kahoots in here? Do you, for yourself? No? The class below you is really good at Kahoots. Like, they make a Kahoot for everything and then they share it as a group. So it's kind of nice to take a topic and then just have a bunch of Kahoots and they load it up to, and everybody plays it when they're at work and stuff. Or like now they're doing the thing where they're going to Espanola, so they're taking that nice long drive out there. So they're doing that when they're in the car. Some other things we need to make sure are normal is our other clinical measurements, which is our AA gradient. Okay, and it should be about 300 normally. Shunt should be less than 20%. A normal shunt is 5%. Dead space ratio should be less than 60%. That should be an M there. You can cross out this M. I don't know what this M is doing there. Go again. Normal dead space is about 20 to 40%. Static compliance is normally around 100%. I want a minimum compliance of 25 mLs per centimeter water. Again, all my blood pressure and stuff have to be normalized. And then make sure drugs are not interfering with the patient's ability to breathe. So again, paralytics have to be off. Sedation has to be off to some degree. And I don't mean like the Precedex or the Ativan or the stuff that's just keeping them kind of calm, but the propofol, you know, the Nimbex, whatever they've got as a paralytic, that stuff has to be turned off. Okay? You got to know these two slides. Any questions? This is also on your quiz. Now, pursing, your other review book has just slightly different criteria. They're pretty damn close. I mean, for example, the RSBI for pursing is 105. Kettering says 100. Your book says 100. Who cares? 100 is good. For your quizzes and stuff, if it's off, it's going to be way off. Like for me, you won't have any issues wondering if it's not good or not. Okay, it'll be so blatantly wrong, you'll know. Okay. Now, pursing also says that you should be at a PEEP of less than or equal to 8. I actually agree with that. I think that's a very good thing. You don't want a lot of PEEP if you're going to excavate, because they do recruit, right? PF ratio should be less than 200 according to them, and the rest of it's pretty similar. Next part, time to get the tube out. You've done everything, the patient's stable, you've coordinated, you have orders, everybody's happy, you're confident the patient's going to do fine. That is the best phrase most conscious people on a vent will hear you say, is that the tube is coming out. So again, this is just here for you to reread how to do the steps. You should know this by now. There's an excavation video for you guys to watch. I'm not going to waste a bunch of time talking about it. Go through these slides. If you have any questions, come to me. If you feel like you need to practice the excavation process again, because it's been a minute since you did it, I'll intubate somebody. You can excavate them if you want to practice that next week in lab. Okay.
Can we also just re-practice at debating them?
Yeah, actually we just did that lab this morning. I had the babies doing gyroscope on this guy and regular intubation over there on the other mannequin. Yeah. They were all excited. They're like, yes, it's so great. That's all the post-excavation stuff. So you've had all this before. Now, remember, if we pull a tube, I need to somewhere before I excavate, make sure I check for a cuff loop, right? So it can be that very second before I pull the tube and I deflate the cuff. I better hear air coming out the patient's mouth, right? That means there's movement around the cuff. You guys already know this. Or if I did my assessment this morning and I looked for a minimal leak technique and I already found it, that they have a leak, I don't have to worry about it when I go to excavate. They didn't just develop Strider in the 30 minutes that it took me to get stuff to excavate, okay? But if you do excavate and there's Strider that's happening, remember for the boards, okay? Mild, you get racemic epi, cool aerosol. Moderate, severe, marked, they get to be reintubated. Okay, look for those words. Marked or severe Strider gets tubed, because you gotta protect that airway. And that's what I'm saying from a board perspective, and that's what the guy from Kettering just told me, and I didn't know this, is that it doesn't mean you have to ventilate them. You just have to intubate them, protect their airway, and then you'll get more data on whether they need ventilation or not. Okay. So the key is between moderate mild, and then marked or severe. Okay? Any questions? Okay, and then I'm gonna show you this picture, and I don't know if you guys wanna take a picture of it on your phone. Here is some of the pharmacology that's gonna be left over for patients in the ICU. Here's some of the drugs that they might be using. So if you're not familiar with these, because it's been a minute, you might wanna take that picture just so you know what the terms are. Oh my lord, I gotta go take some ibuprofen. Okay, we'll take a break, and then we're gonna practice some board questions. I'm gonna show you some of what, some of the Chinese monkey stuff you're gonna be looking at.